Okay, I'm going to begin by going over some renal diagnostic procedures. These are used to evaluate kidney function in different methods. To begin with is radiography, which is an X-ray. Typically, we're looking at a KUB, which stands for the kidneys, ureters, and bladder. Sometimes you'll also hear or see an order for a flat plate. That's what a KUB is. So we're just looking at the visualization of the structures, and prepping for that, you want to make sure that your patient, if a female, is not pregnant, and they need to remove their jewelry and medallions, obviously. They could also go for a renal dye could be inserted, contrast medium, which is could or could not be iodine based. It may or may not be on non-ionic or ionic based dye, and that helps with the images. And you want to make sure that you check for a iodine allergy in those patients. As always, with anyone who's getting the dye, ionic or non-ionic, whatever it is, the contrast medium, it can cause renal failure. So you always want to make sure that what your patient's creatinine levels are, and they may need a fluid flush following to prevent any kind of renal insult. CT scans are also done, and that looks at a cross-sectional image of the kidney to assess the size and to look for any obstructions, cysts, or masses on the kidney. And the prep is the same as a KUB. An MRI, often they'll use that for staging for cancer. It's very similar to a CAT scan, and want to warn the patient that they have to lay flat, that they may or may not go into a tube depending on the type of MRI the facility has, if it's an open or the actual tube. So you would prep them that way. The IV bolus and fluoroscopy, very similar to the what I talked about for being infused with contrast medium, and they use that to look for stones, the location, as well as renal function. This is not to be done on pregnant women. The contrast dye, you have to make sure that the patient is not allergic to it, and then flush following. The VCUG is avoiding cystourethropography. I hate these. Back when I used to work in interventional radiology, we would be doing these on children, and what it does is it outlines the bladder shape, and it's looking for urinary reflux and what angle the ureters come into the bladder. If they have an odd angle, then they get some reflux, and then they are susceptible to infections and renal failure later on in life. And it can increase the risk of infection, and the patient has to be monitored for the first 72 hours following the procedure. So what avoiding VCUG is actually insert a catheter into the child, and then you infuse, I say child, whoever the patient is, and then you infuse contrast medium into the bladder, and then KUB is done, a flat plate, and then they can see the outline of the bladder and see what angles it comes in at. Kids don't like this one. This is the one part of my job I always hated. Let's see what's next. A renal biopsy. That's where they just go take a little sample of the tissue. They usually use a fine needle, go in through the flank, and then get that aspiration for a cystological or histological examination. The patient is often sedated, and it's monitored through the procedure. Complication could be infection. They need to lie on their back postoperatively to prevent bleeding. So we want to make sure that we check the site for complications of bleeding as well. Cystoscopy, that's where they look for abnormalities of the bladder wall, any occlusions. Patients are given an anesthetic, and then they go in and they look with a scope up through the urethra. You want to check post-procedure for signs of bleeding and infection, and make sure that the patient is monitored for 72 hours for those signs and symptoms of infection and bleeding. A renal scan is to assess the renal blood flow and function, and complications. No, pardon me. Renal scan. I'm reading ahead on myself. We want to talk about for renal scan that 48 hours prior to that procedure, ACE inhibitors should be held, and medications can be given during the test, and you want to watch for hypotension as well. And then ultrasound is just to look at the size of the kidney, any obstruction in the lower urinary tract. That has a very minimal risk, and it's a good option for patients. So, complications, I was going to talk about those. Anytime you have any kind of invasion, we could have bleeding. If we're doing a biopsy, we want to make sure that we are, if the bleeding does occur, we notify the provider immediately. Many of these procedures may have caused blood in the urine because of we've invaded that space, so to speak, and it can be also a complication of renal biopsy. So you wanted to watch a patient's urine output closely, and the color and the amount. If there is bright red blood or clots, you want to make sure that you notice the physician immediately. Now, renal failure, remember I mentioned that about the contrast dyes. That can cause renal failure. So you always want to make sure that you know your patient's creatinine level prior to the procedure. And often patients are given parenteral fluid to flush that dye out. And we want to make sure that we don't have patients who have complications of too much fluid overload, so we don't put them in overload afterwards as well. Infection can result from some of these tests, and we need to monitor the patients for 48 to 72 hours. And that's not keeping them in the hospital. That's a follow-up phone call sometimes that is given by the nurse. Well, which is given, not sometimes, which is given by the nurse in the department following. And you're asking about temperature, if they're unable to void, if they have any pain, that kind of thing. So those are the renal diagnostics that we typically see that are used.